Yes, sir. Uh, Good morning, everyone. In this class, we'll see the article which deals with the correlation between intraoperative NIRS and the neurologic outcomes in patients undergoing total aortic arch replacement using frozen electric trunk technique. This is a retrospective single-center study. In this study, 427 patients were included with acute and chronic aortic pathologies between 2013 to 2023 by frozen elephant trunk procedure. Out of this 427 patients, 166 patients with complete NIRS data throughout the surgery were included, and they were divided into two groups. One group is with stroke post-procedure and other is without stroke. Bilateral NIRS values were recorded throughout the procedure and were noted down at 7 critical time points. Both left and right-sided NIRS values were monitored. The main complications following this procedure were bleeding, spinal cord injury, stroke, and thromboembolic events. Stroke is one of the most dreaded complications, which ranges from 7.6 to 20% post-surgery. In an attempt to minimize the peri-procedure stroke, neuromonitoring methods such as NIRS have been developed, and it is used to monitor the cerebral oxygenation throughout the procedure. The aim of this study is to test whether the intraoperative NIRS value differs in patients with and without stroke post-procedure. Two studies were used to evaluate perioperative stroke, that is modified Rankin scale, and one more is National Institute of Health stroke scale. According to National Institute of Health stroke scale, the score was 1 to 4 is minor stroke, 5 to 15 is moderate stroke, 15 to 20 is moderate to severe stroke, and more than 20 is severe stroke. According to modified Rankin scale, no clinical symptoms are given 0.0, no significant disability is 1, and slight disability is 2. To determine the magnitude of brain infarction and to identify its etiology, whether it is embolic, hemorrhagic, or hemodynamic, two imaging modalities were used. Mostly used is CT brain, and rarely MRI brain is used. Intraoperative neuromonitoring was done using NIRS electrodes, which is connected to patient's forehead, which monitors the frontal cerebral oxygenation using cerebral oximeter. Baseline RSO2 values were evaluated and recorded during timeout procedure. All such were performed through full median sternotomy and using SACP throughout the procedure with moderate hypothermic circulatory arrest. The studied outcome is stroke during the frozen elephant trunk procedure. NIRS values were measured throughout the procedure and noted down at 7 critical time points. So the 7 time points were 30 minutes before CPB and at the start of CPB, during cross clamping of aorta, start of SACP, and minimum RSO2 noted during SACP, end of SACP, and end of cross clamping of aorta. At these time points, the risk of stroke due to embolism, mainly during cross clamping or hypoperfusion during SACP, is highest. The overall stroke rate in this study, including both acute and chronic aortic pathologies, is 13.9%. Patient who suffered a perioperative stroke has a had very strong correlation with diabetes. No other significant differences found between two cohorts. In this chart, we can see diabetes mellitus has a very strong relation with post-operative stroke with a p-value of less than 0.05, where history of coronary artery disease, previous history of stroke, previous cardiac or aortic surgery has no correlation with post-operative stroke. hypertension, dyslipidemia, and previous valve replacement, so no correlation with postoperative stroke. The patients included in this study mostly underwent surgery for chronic aortic pathologies, around 69.9%. Around 30% underwent surgery for acute aortic pathology, but both acute and chronic etiology has no correlation with postoperative stroke. And the dissection extension, whether it is through subclavian, common carotid, vertebral, descending aorta, abdominal aorta, this all had correlation with postoperative stroke. And preoperatively occlusion of right subclavian, right common carotid, and vertebral, and also on left side has no correlation with postoperative stroke.
What new things did we learn from
36
this?
point. Sir,
Okay,
only strong.
okay, go on, go
Strong.
on. Sorry, I
Yes, sir.
interrupted you. Go on.
No, no, sir.
Continue.
Around 36. Yes, sir. Around 36.9% of patients underwent concomitant cardiac and aortic procedure, but it has no correlation with postoperative stroke. Can see the duration of surgery, total CPB time, cross clamp time is more in stroke patients, but statistically it has no significant relation. The only significant correlation with post-operative stroke in this is lowest temperature in stroke patients. The in-hospital mortality and duration of ICU is more in stroke patients, and post-operative dialysis procedure and tracheostomy rate is also more in stroke patients, and it is statistically significant. Difference in NIRS levels at specified time points in both cohorts. There were no significant difference in perioperative left-sided NIRS values in both cohorts, whereas in right-sided cerebral oxygen saturation yields statistically significant result. The inter-hemisphere NIRS difference between both hemispheres is also statistically significant. So in this table, you can see the RSO2 values of both hemisphere at 7 critical time points. So the minimum cerebral oxygen saturation, it was less during SACP administration. This chart we can see the cerebral oxygen saturation of right hemisphere is less in stroke patients compared to no stroke patients, whereas cerebral oxygen saturation of left hemisphere has no correlation between stroke and no stroke patients. Throughout these 7 critical time points, both stroke and no stroke patients had same RSO2 values of left hemisphere. Mean inter-hemisphere difference between stroke and no stroke patients, it is more in stroke patients when compared to no stroke patients. According to this study, the major finding was NIRS is a reliable tool to monitor intraoperative frontal lobe cerebral oxygen saturation, but its use to predict postoperative stroke remains limited. NIRS does not seem to show perioperative diagnostic value regarding stroke during this procedure. Even regarding frontal stroke, there was no difference in NIRS during surgery in patients with and without stroke. This is because in NIRS, mainly the frontal lobe saturation is monitored with electrodes, and it has low sensitivity also. NIRS to have a predictive effect when considering values for right cerebral oxygen saturation, and it was statistically significant. Stroke in this aortic arch surgery was mainly due to embolic origin. So if there is a stroke, we will expect a decrease in RSO2, and it will maintain a plateau at a lower level. One reason for lack of sensitivity for NIRS could be the positioning of electrodes. It is placed on the forehead of the patient, and it mainly monitors the saturation of frontal lobe. Other lobe saturation were not monitored. Mostly the post-operative stroke occurs in occipital lobe, but occipital lobe saturation is not monitored through NIRS. However, new techniques such as frequency domain NIRS tells about cerebral blood volume and perfusion and oxygen consumption. Other new technology is multi-channel NIRS, which utilizes more than 50 electrodes. So it monitors not only the frontal lobe, the other lobes of the brain also, but it monitors only the superficial cortex only. Both NIRS and multi-channel NIRS monitors only superficial cortex. There is no penetration deep into the brain. During surgery, the only significant difference between two groups was lower temperature during DHCA in stroke patients, as hypothermia, especially during SACP, is usually considered neuroprotective. This seems counterintuitive at first glance. Recent studies suggest DHCA causes increased risk of stroke compared with moderate and mild hypothermic circulatory arrest during aortic arch surgery. The reason why DHCA causes increased risk of stroke is in DHCA, the circulatory arrest is complete, whereas in MHCA, the circulatory arrest is not complete because we are administering SACP throughout the procedure. So stroke risk is lower in MHCA compared to DHCA, and embolic clearance is also more in MHCA because through SACP, the embolus gets washes off easily, and reperfusion injury is lower in MHCA, whereas in DHCA, due to complete arrest, the reperfusion injury is higher, and coagulopathy is also more severe in DHCA. Summary: NIRS, near infrared light is emitted from a source on the scalp. Right, light penetrates scalp, skull, and only the superficial cortex. NIRS doesn't monitor deep into the cortex. It monitors both oxy and deoxyhemoglobin, which observes light differently at specific wavelengths. A detector measures the amount of light that returns. So the normal value of NIRS saturation is more than 60. If it is less than 50, there is likely cerebral hypoxia and we need to intervene. So mainly the baseline RSO2 is monitored before the incision during the timeout procedure. If baseline, if the RSO2 decreases more than 20% from baseline, even if it is above 50%, it indicates cerebral hypoxia. So when NIRS is low, these all things we need to monitor and correct it. If there is hypotension, we should increase the pressures with more fluids or vasopressors, and we should maintain a MAP of more than 60. And we should correct the lower hematocrit, that our target hematocrit should be more than 25%. If there is low saturation, we should increase FiO2 or improve the ventilation. We should see the ABG whether there is hypoxia and hypercarbia. Both causes deoxygenation. In hypercarbia due to acidosis, the tissue cannot utilize the oxygen. In hypocarbia, the oxygen binds to the hemoglobin more effectively and oxygen cannot be released off. We should maintain a SACP flow of almost 10 to 15 ml per kg per minute, and we should monitor the SACP pressure also. It should be around 50 to 70. If NIRS value is low, and if we should increase the SACP pressure, and we should avoid the excessive SACP flow. It may increase the intracranial pressure and cause cerebral edema. When NIRS is low, we should see whether the SACP is going to the correct side or not. If we are giving only right-sided SACP, in some patients the circle of Willis might be incomplete, so left side cannot get perfused. In those situations, we should perfuse both side cerebral and whether the SACP line, if there is any kinks, airlock or clot in the line, and we should see the cerebral perfusion pressure, which should be around 50 to 60, and mainly we should see the head positioning also. Head should be in neutral position. The head should not be turned. It might compress the neck vessels, and there should be no external pressure on carotids or jugulars. So in recent times, the FD NIRS value is under research. It is not in clinical use. The FD NIRS monitors value of oxyhemoglobin, deoxyhemoglobin, total hemoglobin, and sensitivity and specificity of tissue oxygen saturation is more in FD NIRS.
What is FDNIRS?
Sir, frequency domain NIRS, sir. It is still under research. It is not in use now. Currently, we are using only standard NIRS. And one more technique we use to monitor cerebral oxygenation is transcranial Doppler. TCD ultrasound, it is non-invasive, and in TCD we see the middle cerebral artery. It calculates speed of blood flow, direction, whether there is any spasm or blockage in the artery, and it gives pulsatility index, which shows the resistance in vessels. Mainly in TCD, during neuromonitoring, we see middle cerebral artery only, and the normal value is 30 to 80. We keep an average of 35 to 40. If it is less than 35 to 40, there can be any occlusion in the artery. If the velocity is more, it means there is vasospasm. Currently, the best way for neuromonitoring during cardiac surgery is multimodal approach, which includes NIRS, TCD, along with EEG. In our hospital, we use standard NIRS with TCD. Thank you, sir.
I told you yesterday you should talk about the background. You didn't. You should have talked a little bit about the principles of NIRS, how it is done, what are the various types, like you said FDNIRS. Suddenly we don't know what FDNIRS is. Okay, so that is one, and also the selective antegrade cerebral perfusion, how it is done, where, when it is done, how it, all these things should have been talked about, right? You may know the first and second years who are attending, and including some, including me, I don't know how it is all done.
Here SACP we give
So
through all
you
our
know,
vessels.
you may know, but when you're talking about a particular article, you should talk a little bit about the background information. And secondly, in this article, I don't know what additional information we got. See, you said that there has been no difference in the this thing pre-op and post-op, this thing after NIRS. It's just that it was an exercise in monitoring these defects, but there is no predictive value.
Yes, sir. That's why
What new information did we get from this article? Why did you choose this article, and what is the point in you presenting this article?
So that's why we don't use only NIRS. We use alongside with the TCD also whenever we have doubt with the value of NIRS. Previously, only NIRS were used, but since the value doesn't correlate, we use alongside with the TCD also.
So that means this article is outdated. What was the date of this article?
Sir, it is recently published, sir, in 2025 only.
But then if they have not included all these things, so there is no additional new information from this article. I don't know.
Sir, in most of other centers only they are using NIRS, but not with other modalities. So mainly says using NIRS monitor saturation only during the surgery. So whenever we have doubt, we should go with multimodal approach only.
Yeah,
in our center we use.
You should have put up a few slides, how it is done, what are the things, in any way. Any comments? I see Rahul is there around. Rahul?
Morning, sir.
Morning. You have any comments to make?
Actually, very limited experience with Dr. Praveen, whatever I've done. But yeah, NIR is very limited role because we just get a predictive estimate of the saturations. So I think this paper or study, what they've done is just to corroborate that we still find it of not much of clinical utility using the NIRS, basically. So one thing, you could have just touched upon what is total circulatory arrest and what is,
We should have talked a little bit about the basics.
Can you tell now also, just on the top of your head, whatever you know, so that the residents can, especially first year and second year, like I know you're not made a slide, but at least you can just tell what is the meaning of selective antegrade cerebral perfusion and total circulatory arrest. There are two concepts in this. So if you can just explain it for about couple of minutes, it'll be helpful for the residents. Go ahead, Balaji.
Yes, sir. During the aortic surgery, so before clamping the aorta, we give for cerebral protection. First, we give retrograde RCP through RA cannula directed towards the SVC, or we directly cannulate the SVC and we'll give RCP for cerebral protection. So throughout the procedure, we can't give RCP because there is increased rate of cerebral edema. So after that, we give SACP through. In our center, we give through all the arch vessels. So if there is any deficit in circle of Willis also, because we are giving bilateral SACP. And there is more brain protection, and we get more time to do the surgery also. And
one minute, yes, Balaji. When you said you're giving SACP through the SVC, right?
RCP, sir.
Or retrograde cerebroplegia, cerebral perfusion, retrograde. That is through the through the venous line, right?
Yes, sir.
So how do you protect both the hemispheres from that? I didn't understand that.
No, sir. Until we start the SACP, we give the RCP, sir.
No, I'm not sure. I'm not sure I understood.
Alaji, one question. Do we still use RCP now in our institute? What is the current this one? because there is a big debate about the actual utility of using retrograde cerebral perfusion. So no, it goes through the phases where sometime for a long time it was, people would swear by it. In between, there was data to suggest that it is not much of clinical utility. What is the current status now?
Sir, we give SACP, sir, through all the arch vessels throughout the procedure. And
So do we use RCP
for
Sir, like
no,
he
no, sir,
said, in emergency dissection cases, until we can make sure that we are reaching the arch vessels or opening up. For example, last time we had this TAVI where a valve was embolized into the arch. So we could not cross clamp, nor could we reach the arch vessels. At that time, we gave retrograde perfusion until we could reach the arch vessels and put in the SACP cannula. So only a transient period of maybe 15 minutes, we could use that.
Correct. What is the other situation where you would use RCP? I mean, this is anecdotal experience, but yeah. This is a classical example of a CPB accident where you would have the pump line pushing in air through the aortic cannula. So, I don't know if you guys have seen this situation. I've had one situation like that. So in that situation also, because whatever the perfusionist pump reverses, and they push in air into the aortic, there's a massive air embolism. So in that case also, you can use an RCP. So like Karan said, in an emergency, until the point where you can establish antegrade cerebral perfusion, you would prefer to use RCP until the point you can use antegrade cerebral perfusion. So the next question, Balaji, would be what are the techniques of antegrade cerebral perfusion? Like technique in a question will be the axis. Like you said, in our institute, we directly cannulate the arch vessels. Is there any
Yes,
other
sir.
way you can do it? This is, yeah. Can you tell me
Sir,
the
through
other ways you
axillary.
can? Yeah. So when you
Sir,
use an
through right
axillary,
axillary cannulation.
correct. Yeah. So you cannulate the axillary artery either directly or generally. Would you directly cannulate the
Through
artery or
the
use
graft. No, sir, through we
to
use
the
a Dacron graft and then we cannulate the
correct?
axillary artery.
Yeah. So some surgeons, what we would do is we would electively cannulate the axillary artery. I mean, using a graft like you said, and keep it ready.
Yes, sir.
And then you would, open, uh, you know, when you do the procedure, then if required, you can actually, cannulate the individual vessels. So what is the problem with the axillary artery selective, you are using
Sir,
axillary artery?
yes. So if we do only like right axillary cannulation, only the right carotid will get perfused. And if there is any dehiscence in circle of Willis, the left side hemisphere won't get enough supply.
Correct. So basically, we are heavily dependent upon the circle for the perfusion when you use only a right axillary. So again, the same
Yes, sir.
principle like what Karan said. If instead of RCP in an elective case, you want to, do half the job and get ready, you put in an axillary artery graft and the cannula. So at least you have one access for SACP, selective antegrade cerebral perfusion. So you
Yes,
said
sir.
we cannulate all the vessels. So can you tell me the steps? Like you would have opened the chest, right? You would have opened the sternum. You would have opened the pericardium.
Yes,
So how do you initiate CPB initially?
Sir, like after cannulation, we will do the systemic cooling to
What would be
to
your
target
initial
temperature of less
CPB?
than
Where do you cannulate? How do you start CPB? Once you start CPB, then only you can start cooling, isn't it? That is what Rahul is asking you. So these basic things you should know. We should have a clear-cut idea how to go about it.
yes.
What are the different ways of initiating CPB? Can you tell me that? This is only for the residents, the basic way of going on CPB when you don't have an access through the IOTA, or if you have an access but you want to initiate CPB, what would you do? What are the various vessels you would cannulate?
Like we'll expose the arch vessels and we'll apply the vascular clamps to it to prevent the back bleeding, and then we'll do the systemic cooling. And
no idea. I didn't understand anything that you said.
So would you cannulate the femoral vessels for peripheral, initially, or, is that one technique you can do?
yes, sir. But there is a high risk rate for embolization through femoral cannulation, sir.
You sure about that? Embolization about what? Of what? Like, I didn't get you. Like, imagine a patient comes with an aortic dissection. So you want to
Yes, sir.
establish CPB. Would you not prefer to open the femorals and the axillary and have an access? That would be easier, right? Would it increase the risk of anything? I'm not sure, because that's the standard procedure what we do.
Yes, sir. No,
Let-
sir, I
let-
meant
let
if
me-
there is any
let me-
dissection or something.
No, let me put it another way. Supposing you have got the chest open, you've got a dissecting aneurysm, and you want to cannulate the aorta, you don't know where the true lumen and the false lumen is. And if you do the vice versa, if you put a cannula into your false lumen, what will happen? Similarly, with the right and left
dissection will
femoral arteries. So similar thing can happen with the right and left femoral arteries. So you have to know where the true lumen is and which is the false lumen. So what we are trying to tell you, Balaji, is that you should know the basics of hypothermic circulation before you talk about all these other things. How to cannulate, where to cannulate, how to establish CPB, and then you start cooling. Then you start monitoring what you're going to do about the brain. You don't know the basics. Now you should have talked about the basics. That's why I told you yesterday that you should have the basic background. So coming back to the original question, how would you establish perfusion in a patient with dissecting aneurysm? Tell me, basic.
Sir, we'll go through femoral artery femoral cannulation. We'll expose the femoral artery, and after apparenization, we'll cannulate and connect to CPB, and we establish the systemic circulation. Once the systemic circulation is established, and then we'll go for SCCP, sir.
Any other technique, Balaji? Imagine somebody wants to cannulate the aorta itself. Is it possible to cannulate the aorta in a dissection or where there is a flap? Is it possible to cannulate the aorta? I know we don't do it in our institute, I think, but there are some centers which they cannulate the aorta even in a dissecting aneurysm. Is it possible to do it safely? And how do you do it?
Dissection will extend if we cannulate the dissecting aorta.
Agree with you. So basically, what is the point? We have to reach the true lumen, correct? So
Yes,
if we
sir.
reach the true lumen and the cannula is in the true lumen, we can still theoretically or practically in some centers, which they do, they still cannulate the aorta. So is it possible to do that with the help of somebody from the head end?
With the TE, we can able to.
Yeah. So either you can use a TE or an epi-aortic ultrasound.
Okay, sir.
Actually, I have no experience in this. I'm just telling you from a paper. So you can actually do an ultrasound, look at the aorta, and see which is the true lumen and the false lumen. And using your same cell digger technique, you pass the guide wire, whatever, and into the true lumen and cannulate the true lumen and establish. Yeah. Any other technique for causing, I mean, for initiating systemic this one? There was an old technique which I only presented on Journal Club when I was a resident, called as a LARA cannulation. I don't know if sir remembers. So basically, Dr. P.V. Rao used to do this.
Correct.
So they would avoid peripheral cannulation. So basically, what they would do is they would the venous drainage would be as conventional with the SVC and IVC or RA, whatever is preferred. The aortic cannula would go into the left atrium. So the principle there was because you are pushing the blood through the left atrium into the left ventricle across the mitral valve, it will go into the true lumen. So with this, you would establish cardiopulmonary bypass, then cool the patient. Once you cool the patient, then once you reach the appropriate temperature, then you would keep the individual cannulas for the arch vessels ready, and then you would once you open the aorta, you would cannulate the individual vessels and you would snug them. So this is one more technique.
Yes, sir.
So you got 3 techniques now, Balaji. One is you can use peripheral
Yes,
arteries.
sir.
One you
Femoral.
can
LARA.
yeah, you can use the femorals and the axillary. The second technique would be using an ultrasound. The third technique would
Yes,
be
sir.
using the LARA. But I think LARA after
LARA.
Dr. Rao stopped, I think we are not doing that.
Yes.
The other problem with the LARA, what thought was because of the raised LA pressure, there's a lot of lung issues in the post-op. Again, not enough data, but that's we are not using it routinely.
One other technique they used to do earlier is through the apex of the left ventricle into the aorta. That means what
Yes,
the
sir,
heart
correct,
has
sir.
been what the heart has been doing already, whether pushing into the true lumen or the other lumen, it is exact same thing. Because if you open the aorta, you don't know which is a false lumen or which is a true lumen. But if you cannulate through the apex of the left ventricle, it goes what has been happening before. So that used to be one technique. Then P.V. Rao did RALA thing, but it was published, but I don't think it gained much popularity in people because that can be done only till the heart is beating. When you take blood from the right atrium, oxygenate and giving to the left atrium through the left ventricle. So that's available only when the heart is beating. So when you are cooling at about 28 degrees centigrade, the heart fibrillates. By that time, you must be ready with cannulation for the cerebral vessels. The other thing is actually most people don't do retrograde cerebral perfusion nowadays. There used to be a lot of argument about 20 years ago, the what is the pros and cons of antigrade and retrograde actually. And then most people are now switched on to antigrade, probably selective to both carotid arteries. The other technique, as you said, through the right axillary artery, then you clamp the nominate so that they in reverse the circulation goes through the right carotid artery, and if the circumvillus is complete, it gives protection. Those days, one drawback of an antigrade perfusion used to be either air embolism or particulate embolism. But anyway, the general impression nowadays is to do selective antigrade perfusion. So the three things: deep hypothermia, circulatory arrest; moderate hypothermia, circulatory arrest; moderate hypothermia without circulatory arrest; and antigrade cerebral perfusion. These are the techniques. And you said the deep hypothermia, circulatory arrest, the complications are much more,
Yes,
And
sir.
the monitoring, started in the 70s when the deep hypothermia circulatory arrest for babies for open heart surgery, not for aortic surgery. That time they used to go by the electroencephalograph to find out quiescence. That we don't do in aortic heart surgery. Transcranial Doppler gives a flow to the middle cerebral artery, but it doesn't give any idea what about the regional oxygen saturation like NIRS. So NIRS also, because you put in the frontal and it's a superficial, you don't get exactly what's happening in the deeper tissues of the brain. So as you said, some more modifications coming using more electrodes. Even then, it's only superficial, near. So some other
Yes, sir.
modification you said is coming actually. And what I didn't understand is all these cases are FETs, is it? Because my knowledge is actually for the surgery of the aortic hearts, it's not FETs. I don't know why every case is FET. What's the difference between usual elephant trunk and an FET, frozen elephant trunk? What is the elephant trunk surgery and what is frozen elephant trunk? As far as I know, for aortic heart aneurysm, we don't use frozen elephant trunk. You use a Dacron graft, a gel weave, a gelatin or albumin coated, less porous graft actually. What is the elephant trunk and what is frozen elephant trunk?
Sir, in classic elephant trunk, we use soft Dacron graft.
Yeah.
Uh, in
For what condition do you,
stented.
for what condition you use that?
Sir, a frozen elephant trunk, if we do any simultaneous endovascular.
What is frozen about it?
Sir, in classic elephant trunk, we Dacron graft is used. In frozen, it is an endograft, like it is stented.
Like as sir asked you, what do you do in which condition? Aortic arch aneurysm, what do you do? And if it is arch extending on to the descending aorta, the dissection is going down below, what do you do?
This only in aortic arch, then classic elephant trunk. If it is like acute dissection or aneurysm extending into the descending, then we go for frozen elephant.
How is it done? This is important, Balaji. You should understand what you are using, why you are using, how you are using. See, arch aneurysm, many of the time, you just do a distal anastomosis and then bring it out, put an island graft or make an island of the arch vessels and then do the proximal anastomosis. Whereas in frozen elephant trunk, you invert the graft and then suture the distal anastomosis, let go the distal limb into the descending aorta, and then do the proximal anastomosis, and then subsequently use a endovascular technique to graft, to put a graft across onto that trunk into the descending aorta. So that is happening when you have an extended dissection going right down to the descending aorta or thoracoabdominal aorta. Or sometimes they used to do a second setting and through the thoracolaporotomy. Now we have frozen. Now we have the endovascular technique, so it is done in a this thing, TVAR sort type of thing, endovascular repair. I'm not too sure about the technicalities and things like that. That is why you should have asked one of your people who do this day in and day out should have been here.
Elephant trunk is usually done for an aortic arch aneurysm which extends into the descending thoracic aorta. In which you do the aortic arch graft or the three main vessels arising from the aorta are grafted to that. And then you use the background graft, you anastomosis to the graft and let it lie loose like an elephant trunk into the descending thoracic aorta. And then as a second stage, you open the left thoracotomy and then you make anastomosis between that graft and the descending thoracic aorta beyond the aneurysm or beyond the dissection. That was the classical elephant trunk operation in 2 stages. But now because endovascular grafts are available, what you do is that you do the arch replacement and then use the elephant trunk, frozen elephant trunk, put it and then on the table as a hybrid technique, you inflate that. So that is a hybrid technique, doing both at the same time using that's why it's known as a frozen elephant trunk, because you dilate it and fix it in a frozen state. That is also an FET. So I don't understand what is FET for aortic arch. The only FET for aortic arch I know is a deep branching technique. As a first stage, you make anastomosis from the ascending aorta to the two common carotids and the to innominate and left common carotid and left subclavian. And as a next stage, you put a endovascular graft, including the descending aorta, including the arch. That's what my understanding is frozen elephant trunk for aortic arch. Otherwise, frozen elephant trunk is usually for the descending thoracic aorta after you have done a surgical repair, grafting of the arch. That's my understanding actually of this. And transcranial Doppler gives only you the blood flow, but it doesn't give you any idea of the regional oxygen saturation.
Yes, sir.
Yes.
Yes, sir.
That there are so many graphs available with 2 branches, 3 branches, all sorts of things are available now. I don't know the names, but I don't
Yeah,
think many people.
you have prefabricated graphs
Yeah,
with
yeah.
limbs to the cerebral vessels.
I don't think we do deep branching technique for aortic arch aneurysm. For thoracoabdominal aneurysm, I think they used to do deep branching technique. First stage, you anastomose all the branches, and as a second stage, for the aneurysm, you do the endovascular graft. Can be done for the arch, but I don't know whether it's practical here or whether it's done here or not.
From what very little experience we had in St. John's, sir, for a arch aneurysm, we used to go on to deep hypothermic circulatory arrest, do the distal anastomosis onto the descending aorta beyond the arch vessels, then bring it out, and then you make a cut in the superior surface of the graft, and then anastomose the arch vessels as an island graft, and then do the proximal. Once we have done the distal descending aorta, then you can start this thing around the arch, and then you can restart the circulation and then do the proximal anastomosis. That's how we did a few cases.
That's done when the upper part of the aortic arch is not diseased. That exactly used to be known as the Carrot's patch, right renal artery, along with little bit of the aorta. This is Carrot's patch. You origin of the nominate and the left common carotid. Taken left subclavian, they don't bother that much. Taken as a patch when that part is not abnormal. The aneurysm doesn't, I think usually it doesn't affect that part. And then as an island it is put. Then later on came different types of branch grafts are available. From the ascending aorta, you can put graft to the innominate and to the left common carotid, and if necessary, to the left subclavian also.
Sir, we have arch grafts available actually,
Yeah,
who have 3 limbs, and there is one extra perfusion arm also, which
Yeah.
we can use later once we do the
Okay.
anastomosis.
Yeah.
Yes.
Commercially, so many different grafts are available with branches now.
Yes, sir.
But I didn't understand why FET for arch. Anyway.
Sir, if at all we have a second stage surgery, like it is a DTA or any abdominal aneurysm is there, which we can't do in single stage, in that way we can use FET. That time, because it is difficult to cannulate there. So we will do a thoracotomy, and sometime we go into left heart bypass, and then we can use that FET part to cannulate and perfuse the upper body. Like you said earlier, sir, if we have a DTA surgery later or anything, then yeah, that's the things. But sometimes we don't use it now very often because we can perfuse separately the lower body.
The problem in these people is actually the femoral cannulation, because many of them
Yes, sir.
have got aortoiliac disease. That's why I think Balaji mentioned that, the problem of femoral cannulation in this thing. The other thing is even if you open the femoral artery, you cannot be very sure which is the false lumen, which is the true lumen, and you may be perfusing the false lumen also. And very often uh, most people nowadays do right axillary cannulation and usually the dissection doesn't extend there and with a graft because you cannot directly cannulate the right axillary artery because the cannula moves a little bit, the pressure goes up, and the dissection and other things can occur. The uh, perfusion pressure goes very high. So it's always a graft is on 8 millimeter graft and then put the cannula into the graft. That's it. That's a classical procedure now. For old people, femoral cannulation may not be the best thing.
Usually the dissecting flap is a spiral flap, and then it perfuses one femoral artery and the false lumen will be in the other femoral artery. So it is very difficult to understand which is the true lumen and which is the false lumen, even if you go on to the femoral cannulation.
I think Venkat used to tell me, because sometimes innominate cannulation, he says, transect the innominate artery because if you just open little bit of the innominate artery, you're not sure which is the true lumen. Whereas when you transect it, he says you can find out which is the true, which is the false lumen and perfuse the true lumen for perfusion of the cerebral arteries. I don't know.
Anyway, this is an important topic actually. Aortic arch and dissecting aneurysm. Somebody should do a seminar on that. And then the different CPV techniques. Then once you have understood this, then you can talk about all the cerebral protection and then the different techniques that are used for that. Okay. Anybody else has any other comments?
So just
Balaji.
one thing I wanted to tell you. So sometimes, sir, when we are not able to cannulate the femoral and there is a dissecting flap there, so can we use SSCP for that from the abdominal side to perfuse the lower body? Balloon catheter.
I didn't follow. What do you do?
We will open the aorta, sir. We will clamp and then open the aorta and perfuse it through a balloon cannula. Lower body, sir.
Open the aorta where?
Proximally, sir.
Where? Proximally where?
Suppose
from this.
yes, sir. In DTA, if it is possible, suppose you are doing abdominal, there is an aneurysm in the abdominal aorta, then we'll open and we'll clamp it in the DTA and we'll cannulate proximally to the clamp and perfuse the upper body. And then we can open the aorta and perfuse the lower body using a balloon cannula.
From what I understand, abdominal aneurysm, you don't need anything to do. You just clamp and then quickly do the distal and the proximal anastomosis. And then if at all you need to do some visceral perfusion, you can use a what we used to use for coronaries, the multi-pronged cannula, and then individually perfuse the renals and the SMA. And then you don't need anything more than that.
Okay. Okay,
But
sir.
if and even the descending thoracic aneurysm, you can just clamp and do it quickly. I mean, the 20 minutes, you'll be able to do your proximal and distal anastomosis within 20-25 minutes. If that is
Yes, sir.
achieved, then it is okay. But thoraco-abdominal, you need to do visceral perfusion.
Yes, sir. Okay, sir.
That you can either use a cannula from the descending aorta where it is good beyond the subclavian artery, and then use that as a perfusion cannula like the multi-pronged coronary perfusion cannulas, and then individual visceral perfusion, and then do the anastomosis.
Okay, sir.
And subsequently, as those things are there, just like what we talked about in the arch vessels, we use a patch technique to reimplant the both the renals and the SMA. If the SMA is good, if the SMA is fine, the and celiac also will come in the same thing. So you can actually sacrifice the IMA, in inferior mesenteric artery.
Okay.
So the island graft will be including the celiac trunk, 2 renals on the sides, and the SMA, which is put as a island onto the Dacron graft in the descending aorta.
Okay, sir.
No, it is difficult to explain these things. Earlier, we used to have physical classes where we had a whiteboard, where we could draw and show you what is what. And in this sort of situation, it is difficult to tell you how it is done.
Yes.
We should go back to our old physical classes. That way there will be more attendance, I'm sure, because we will keep a tab on who's attending and who's not attending.